The film shows beta TCP strips being used to create a sinusal partition prior to dental implant reconstruction in 2 clinical cases. A CT scan is used to evaluate the clinical status. The left sinus is visible. It will receive a beta TCP strip and biomaterial. The red line shows the status at outset, and in blue is shown the post-extraction resorption area. The residual aspect of the bone can be seen on the front and profile views. The procedure begins with the opening of a maxillary bone flap. The mucosa is incised along the crest, exposing the maxillary bone plate. A sinusal flap is then opened using a round dental burr with irrigation and taking care to avoid insult to the Schneiderian membrane, together with progressive inward impaction, creating a neocavity into which the beta TCP strip and biomaterial will be placed. After CT scanning evaluation, the beta TCP tricalcium phosphate strip is prepared and adjusted to the exact dimensions of the sinus floor and placed using the mortise technique progressively and with gentle impaction so as to protect the sinusal mucosa and prepare for subsequent safe filling of the neocavity with biomaterial. The beta TCP strip will be fully inserted into the maxillary bone, bonding completely with the bone so as to achieve optimal biomaterial densification. Finally, the wound is sutured. In a second clinical case, shown here, we find perfect biomaterial integration under the beta TCP strip and note the total absence of any mucosal inflammatory reaction due to the contact with the biomaterial. Also to be noted, particularly good densification of the biomaterial. Mucosal incision offloading along the crest, exposing the maxillary bone plate. The mucosa is detached with care so as to avoid any periosteal insult. Exposure of the area where the beta TCP strip and the dental HP biomaterial were placed. The external wall of the maxillary is left untouched, and there is progressive exposure of the augmented area. Observe how closure of the penetration area is complete, with very significant density of the graft material. Small external particles of the biomaterial can be seen bonded to the bone. The strip is held rigidly by the maxillary and can be smoothed under irrigation. 3 implants, 12 mm in length and 4.1 in diameter, are placed. The procedure begins with pre-drilling to locate the ideal position for the 3 implants. Irrigation is provided throughout drilling with a succession of drills to fit the implant length. The first implant is placed in the FDI 25 area, length 12 mm. Excellent bone density is to be noted, so that the 3 implants can be positioned. The implant is removed from its sterile blister using the implant holder. These are 12 mm implants selected for their surfacing, their double thread and flared neck to ensure primary blocking at bone crest. The implant is gradually inserted. Note the excellent bone quality at the graft site and primary implant blocking. A contra-angle handpiece is used for final blocking. A healing cap is positioned as this is a one-stage implant procedure. The second implant is now put into position, again with irrigation, 12 mm length and a perfectly reconstituted bone. This is also an Aesthetica implant positioned over 12 mm and a 4.1 diameter. Once it is in position, another healing cap is placed. Observe on the various views that there is no migration of the healing bone in the maxillary flap area. Follow-up radiography after placement of the 3 implants. A vicryl interrupted suture is used to close the surgical field. Patient follow-up is arranged for 2 weeks later. The beta TCP strip, inserted using the mortise technique, will gradually bond to the maxillary bone, and the underlying grafted tissue will undergo progressive, completely safe bone remodeling. The beta TCP strip will have provided the partitioning needed for the sinus lift procedure, so that there is no need for iliac or cranial corticocancellous bone grafts, thus avoiding a certain degree of surgical morbidity and reducing considerably the cost of procedure.